hear her teach with our child fellows this morning. She is the president and founder of a nonprofit 501c3, which is called Seventh Generation Foundation. And it was established in 2014 to raise awareness and to develop programs for folks with neurodevelopmental disorder associated with prenatal alcohol exposure. She graduated from North Carolina State University with a Bachelor of Science in Microbiology, the University of North Carolina at Chapel Hill with a Master of Public Health in Health Policy and Administration, and a Doctorate of Medicine from Georgetown University Medical Center in General Psychiatry and Children's National Medical Center in Child and Adolescent Psychiatry. She's researched and spoken nationally and internationally and has written a book on the topic of prenatal alcohol exposure, and she is currently developing a community-based farm animal sanctuary for children with neurodevelopmental disorders and anxiety disorders to have social, recreational, and vocational experiences. Please join me in welcoming Dr. Susan Rich.
Thanks so much, Kristen. And can you guys all hear me? I feel like I'm talking into a, I don't know, a water jar or something. I have a cold. But just one clarification, I graduated medical school and public health school from UNC Chapel Hill. Go Tar Heels. And then Georgetown was for residency in psychiatry and then child psychiatry at Children's National. But I'm true and blue Tar Heel, even though I also went to NC State. That kind of makes me a little bit bipolar, right? But anyway. So I'm here today to talk to you about a condition that is prevalent and misunderstood, which is neurodevelopmental disorder associated with prenatal alcohol exposure. We don't necessarily diagnose it, but if we were diagnosing it, I do think that we could improve prognosis in children. I'm going to try to, okay, I don't have any disclosures. I had already sent you guys my gaps in the need. Do I have to go over those, or I can just show you on the slide? Okay, because I wouldn't want to. Okay, so I'm going to, in full disclosure, take you back to 1992 when I was working in pharmaceutical research, doing clinical trials, drug development with Burroughs Wellcome Company, which was then later bought out by GlaxoSmithKline and a bunch of other people. But at the time, I read a book called The Broken Cord, which is about, is the story of a Native American man who raised a little boy and then two other children with what we now know as fetal alcohol syndrome. But in 1972, when Michael Doris adopted his son, Abel, they had barely coined the phrase fetal alcohol syndrome. So that book actually changed my life. I left my job in pharmaceutical research, being the first person in my family to go to college. And I went back to school and did a Master of Public Health and then a Doctorate of Medicine. That's all around the issue of fetal alcohol syndrome. And as you guys see from this picture, I don't know what I just did. This picture, I was trying to get the little pointer. Okay, here we go. So if you see, the face of this child is obviously dysmorphic, but dysmorphic children only account for about 10 to 15% of the cases. And this is a woman from, a birth mom from Ireland and her child, who are kind of seen as the face of this condition, which is largely why we don't necessarily see it in psychiatry, even though we look at it every day of the week. And it's because too many of the children are misunderstood as being behavioral issues because they don't have the face. Only about 10 to 15% actually have the face. So that said, I went on and wrote my own book and speak now nationally and really internationally. I've been doing that for 26 years. I can't stop. So forgive me if I get a little bit impassioned in the talk. I'll try to hold myself back. But we actually now know that it's not just the children with full fetal alcohol syndrome or even the children with alcohol-related birth defects like cleft lip and palate and hypospadias and many other issues that prenatal alcohol can cause, but it's these kids who we used to know as having alcohol-related neurodevelopmental disorder. That's about 85 to 90% of them, who in DSM-5 we now know have neurodevelopmental disorder associated with prenatal alcohol exposure. And I'll be going through some of the criteria that are in DSM-5 in hopes that when you're looking at some of the children that you see, you start seeing them for the pink elephant in the room and not the zebras, because these kids are way more common than zebras. This is like horses, and we're in Kentucky, which is the capital for bourbon, and you need to think that this condition is going to be pretty prevalent here. I'm not saying that Kentucky is alone in that phenomenon, but that said, we know that it's anywhere from 1% to 5% of school-age children. There are some studies to show that it's as high as 1 in 10 kids have this condition. And we know that it's probably as common as Down syndrome, spina bifida, cerebral palsy, and autism combined. So if you look at the rates of autism, cerebral palsy, Down syndrome, and spina bifida, you can see why the CDC is saying it's as common as all of these combined. And a colleague of mine who wrote the foreword in my book, he's a Distinguished Life Fellow in the American Psychiatric Association, Dr. Carl Bell. He has shown in Southside Chicago that this condition may be even as high as 40% in his population. It's a psychiatric clinic embedded in a family practice clinic. And what he did is he went back retrospectively and looked at hundreds of cases of individuals who previously had been diagnosed with things like ADHD, bipolar disorder, NOS, psychosis, NOS, schizophrenia. And because he's worked in that same clinic since the early 70s, he actually knew all of the moms. So he was able to call them up and ask them whether or not they had used alcohol at any point in pregnancy. And many of them admitted that they did because they trusted him. And many of them said that they quit after they found out they were pregnant. But a lot of damage happens in the first 8 weeks post-conception, and that's prior to pregnancy recognition. So if you're only asking a woman, did she use when she was pregnant, she may say no. So we need to get at that in a different way. So that said, we know that in foster care and children from foster care and adoption, that rates are relatively higher. A study that's recently published, that was back in January 2015 by Ira Chasnoff, shows that many of the individuals had either misdiagnosis or missed diagnosis of prenatal alcohol exposure related problems. 156 met criteria for FASD, for any FASD, and that's about 28.5%. So if you look at the population rates, this is a much higher rate in this population. And he indicated in the studies that many of the children had not only never been diagnosed, so 80.1% of that 28.5%, but 6.4% needed their diagnosis changed. So do you guys see a lot of children from foster care and adoption in your clinics? And do you ever wonder why there are many children from foster care and adoption that end up gender dysphoric? Because that's another statistic. Do you ever wonder that, or have you seen it? Have you noticed it? Gender dysphoria, or let's say gender identity disorder, or not necessarily that, but any range of issues. Have you seen that here? Or no, not really. Well, nationally, we see that there are higher rates of that problem. And again, it goes back to Alcohol is an estrogenic compound. It effeminizes the male brain and masculinizes the female. It can cause things like hypospadias in children. Do you know hypospadias? A lot of you are pediatricians, so you know the penile opening being in the wrong place, and that can happen. It's a midline defect, but it's again really how alcohol affects the hormones in development that these things happen. Now that said, it's a very high cost to this $220 billion industry, the alcohol industry, high cost due to FAS alone. And again, FAS is only accounting for 10 to 15% of the affected children. So if you multiply that by exponentially, that would be like what, 2 to 3 more times children with the range of fetal alcohol spectrum disorders, then you can see it's a really high cost that our society is handling and paying for this industry. And I know that at any point the bourbon industry is going to come busting through the door, right? Is that going to happen, or you guys are going to protect me, right? I'll just go and hide somewhere. No, I'm just kidding. So in DSM-5, we've been able to now at least get recognition that many of the childhood, what we used to call mental disorders, are neurodevelopmental. So the neurologic basis of mental disorders. That really makes me a little bit angry, to be honest with you, because if we know that there are etiologies for many of the neurodevelopmental disorders, then why are we not doing something from a public health point of view about it? And again, I have a Master of Public Health. I went to medical school to enhance my MPH, not the other way around. So I probably wouldn't be here today talking to you if I only had an MPH, right? Probably. So you see my point. But now we know that in DSM-5, we can at least start talking about these children with neurodevelopmental disorders associated with prenatal alcohol exposure up under this code F88. This is the only example given under this code. It's on page 86 of DSM-5, whereas in the back of the book, in conditions for further study, there is neurobehavioral disorder associated with prenatal alcohol exposure. We have been able to get the nomenclature clarified because it's the same disorder. It's just that the people who were working through the Interagency Coordinating Committee on FASD, the CDC, and many other agencies, were able to work with the Substance Use Committee for DSM-5 to get neurobehavioral disorder associated with prenatal alcohol exposure in, and they got it in conditions for further study, even though we've had over 40 years of research showing that this is a viable condition. It's just that nobody wants to admit it, but we all use it in our formulations, right? Biopsychosocial formulations. What's one of the leading biological indicators that we would write about in our formulations? Indicators for mental disorders. Alcohol, prenatal alcohol, right? You guys, have you ever written a formulation to include a biological hit from alcohol? Yeah, everybody, some people are nodding. But it never translates into our treatment plan, right? We're going to have it be a diagnosis so that we can begin to develop algorithms and clinical protocols for treating these children, evidence-based medicine. Now, in DSM-5, we have a number of criteria that are given. And for all of these criteria, because the children don't necessarily need to have the characteristic facial features, they don't, this is independent of their facial features. You do need to know that there was more than minimal exposure to alcohol at any point in pregnancy. Now, with that, a lot of people would say, well, if they're adopted, how do you know? Well, if the child was originally taken away from the birth mom because of substance use at birth, then you have a high suspicion that the child was prenatally exposed, right? And you don't have to have been there to see her drink to be able to show that this has happened. You can ask family members if the child is in kinship care. You can, a lot of times through the foster care system, find answers. Now, we're not trained to do this as psychiatrists. How many psychiatrists versus, say, social workers or psychologists are in the room? Are almost all of you psychiatrists? No? Okay. And how many are, like, say, social workers or occupational therapists? Or so those are the one, you know, the people who are more in that field are maybe more trained as what I would call, you know, historians, meaning we're trained to do histories too, but those guys really get it. And a lot of the people who I work with who are social workers, you know, they know to call, you know, the social work agency where the child was placed from and things like that. So to me, the more than minimal exposure to alcohol during gestation, let me go back to that one. In DSM-5, it says at any point in pregnancy, the woman admits drinking at least 2 drinks. Now, none of us believe, nobody believes that 2 drinks alone at any point in pregnancy is enough. But if she's willing to admit 2 drinks, she probably drank 4. And if she's willing to admit 4 drinks after knowing she was pregnant, or 2 drinks, let's say, after knowing she was pregnant, she probably drank more than that before that, okay? So that's kind of where the logic, it was not my logic. I did not, you know, I didn't come up with this, but I think that's the logic behind it. And there's 3 or 4 pages that talk about this diagnosis in DSM that you can read about that if you want more information. And I've just paraphrased the criteria, but as you see here, impaired neurocognitive functioning, they have to have at least one of these. And in DSM-5, even though these criteria say IQ of 70 or below, we know that with the intellectual disability disorder criteria, it's now 75 or below. That was changed in DSM-5. So this didn't match the IDD because these folks weren't working with the IDD folks when they were doing this. It all came together at kind of in silos, if that makes sense. And then at least one of these have to be present. And one of item C in the area of self-regulation. So impaired neurocognitive functioning, impaired self-regulation, and impairment in adaptive functioning. And in this category, you have to have 2 or more of these 4 deficits. And of these 4, 2 of them have to be either communication or social communication and interaction. And the communication relates mostly to language, so a speech and language issue. So people will say to me, now, do you have a multidisciplinary clinic that you are having a speech and language therapist and an OT and all the people showing this? No, because there are people in the community who are occupational therapists and PTs and speech and language, and they're able to do these assessments by referral. So you'd want to, if you're, let's say, in private practice, you can still make this diagnosis in even very young children, but you have to refer them to the allied health professionals to do some of the assessments. And then, of course, like all the other disorders, it has to occur in childhood, and it has to be causing distress. And it's not better explained by postnatal use of other substances, general medical condition, or genetic conditions. So it's still an area of rule out. So you have to refer them for genetic screening, you know, microarray, chromosomes, that kind of thing. This is another way of looking at the same thing. There's NDPAE, which is very similar to IDD, but different domains, with neurocognitive, self-regulation, and adaptive functions. Now with IDD, the difference is you have the adaptive functioning deficits of IDD that are conceptual, social, and practical. And many of the children with NDPAE do have IDD if you only look at their adaptive functions. And so this is where many of them will fit criteria for developmental disability when it comes to services. But most often, people don't know to be looking at adaptive functions, let's say at early ages. And the child may have really good expressive language, but their receptive language isn't that good. So because they're talking, nobody is really appreciating that they might have underlying more severe deficits. So what I do is, for all the kids I see and those that I do evaluations for, I also have a Vineland done or an ABAS. And most people that work with these kids recommend that, because you're not going to see the level of impairment unless you do those tests. And the other thing is neuropsychological testing by the time they get to be school age, to rule out things like executive functioning issues and that type of thing. Now, again, a lot of these problems are happening very early in pregnancy, at the point at which the woman has just barely missed her menstrual cycle. So between so gastrulation and neurulation, which teratologists will say is the most important point in our whole lives. Have you guys heard that before? That gastrulation and neurulation is the most important? Anyway, I happen to believe it. It's really for women who are binge drinking and using a moderate amount of alcohol even. It's a problem, because many of the women may not realize they've missed their period because their periods are not that regular. And again, it goes back to alcohol being estrogenic. It's an estrogenic compound. It's affiliated with and associated with breast cancers. How many of you know that? Okay. So again, I'm right here in Kentucky. I am walking on thin ice because you guys are the bourbon capital. But I'm hoping to get out of the airport. Maybe I'll wear some big sunglasses on the way and a hat. But at this point in pregnancy, when the women are in the most vulnerable stage for their embryos, most of the women don't even realize they're pregnant. Now, that said, my mentor from UNC Chapel Hill did the work in embryos, mostly mice, although some of her micrographs or electron micrographs are from human embryos, just showing that they're relatively similar to the mice. She did her research at the time in the embryogenesis when the embryos are the size of Lincoln's bow tie on the penny. So the woman doesn't know she's pregnant. She's not feeling the baby kick. She's not aware that the embryo is inside her. So I always find it ironic that we are the most susceptible to, let's say, our parents' lifestyle behaviors before our parents even know we exist. And this is something to be teaching in high schools and elementary schools. We actually, Dr. Sulik and I developed a documentary which she went on and produced a curriculum for schools for 5th grade to high school, and that's available through Carolina Biological Supply. But that said, again, a lot of her work was done in the mouse, which in the embryonic and early fetal period is very similar to the human. Mice are born at about 20 days, and mice and rats both, you can do work with them after birth that's equivalent to humans when they're still in the womb. But these early stages, again, of the human embryo are particularly vulnerable. And they're vulnerable not just for physical birth defects like agents similar to thalidomide and Accutane, retinoic acid derivatives, but also very sensitive to functional birth defects. So these are neurodevelopmental disorders. So as psychiatrists, just starting to understand that neurodevelopmental disorders are actually functional birth defects. Okay, and teratologists have been talking about this for years, 100 years. And people aren't getting that. Like, psychiatrists aren't being taught this. But if we were, then we'd be more public health oriented, the way the dentists became when they found out that bacteria caused tooth decay, right? Remember back in the 70s and 60s when they used to go around in schools teaching about brushing and flossing? Anyway, so again, the face forms in the late 3rd to early 4th week. So the children who have the face, it's actually been due to exposure very early on and fairly high amounts, so 4 to 5 servings of alcohol. And one would say, well, 4 to 5 servings of alcohol is a lot. But when you have college students going out, binging, and they're just getting started, this is what I hear from college students. They just get started as a pregame with 4 to 5 shots, and then they go out. And if you think that they're stopping that use when they get out of college, their tolerance is high and they're continuing to party. And then they get pregnant because, they get married and they're drinking pretty heavy, and maybe they stop, maybe they don't. I think many women do stop when they're pregnant, but prior to pregnancy recognition, they may not realize. So what Dr. Sulik showed, and again, her work was done and published in Science in 1981, which is kind of why I'm all fired up. Why does every American not understand this, and every alcohol consumer understand this? The same deficits that she found in the mouse exposed to the equivalent to 4 to 5 drinks in the human causes the facial malformations as early as the late 3rd to early 4th week. And again, if you look at the eyes being small and wide set, that's what we see in the human. You see the midline defects of the face, the nose being smaller, and the philtrum being elongated. And again, it's because when the face zips up during development, the midline of the face, there's not, kind of living cells there, so it has to stretch, and that's why they call it mid-face hypoplasia. So you see the philtrum is a little bit indistinct, and the upper lip is a little thinner than it should be. I'm sure most of you have seen the pictures like this, but this gives you another representation. So a normal mouse face and a normal human face with the philtrum and the ala of the nostrils, and then you see the mouse that had been prenatally exposed and the human, the differences. This is another representation of the same, and this shows the University of Washington at Seattle's lip philtrum grade. So if you look at it, it is different based on ethnic groups. So you see this group of individuals have varying degrees of, these would be considered normal philtrum and upper lip. And as you get with varying degrees of prenatal alcohol exposure, this would be a grade 4 out of 5. So the philtrum is elongated. The upper lip is a little thinner. It does have a cupid's bow. So very often these kids are missed. And this child, even though the philtrum grade is 4 out of 5, it's still considered within range of prenatal alcohol exposure. This one has a non-existent philtrum, is very elongated, and a very thin upper lip lacking the cupid's bow. Now in African Americans, you find a little bit different lip philtrum grade because the lips tend to be a little bit fuller. So by the time you get to the 4 and 5 out of 5 philtrum grades, the lips are not quite so thin as the Caucasians. And the face does continue to mature during development. But Again, much of this is happening when the face is zipping up and the brain and spinal cord are zipping up. And when it doesn't close at the cranial end, you get anencephaly, and when it doesn't close at the caudal end, you get spina bifida. And spina bifida and anencephaly can be created by prenatal alcohol exposure. So people talk about using folic acid to help, and that does, but you also want to consider contraception for people who are using alcohol to prevent this from happening. Just showing you some of Dr. Sulick's work. Again, 4 to 5 servings of alcohol equivalent given to pregnant mouse dams in the late 3rd to early 4th, what would be that in the human, and harvesting the pups 12 hours later, she found all these areas of programmed cell death, so apoptosis. And if you look at the control mice, you don't see that same thing. And if you don't have a penny and you're at a cocktail party and want to tell people this, which I encourage you to do, by the way, you can pull out your dime. And we are about the size of Roosevelt's ear on the dime at this stage when we are highly vulnerable to the effects of alcohol. We're vulnerable at any point in pregnancy, but it's prior to pregnancy recognition that we're particularly vulnerable. Now, this is anencephaly, if any of you have seen it. And just saying that this child, this, fetus that was born, unfortunately dead, has the face of fetal alcohol syndrome, and nobody would have ever said that probably to the mother, right? Now in the mouse, you see even babies that the mouse babies that don't have the facial features that were prenatally exposed that have anencephaly. And this one does have facial features, but has anencephaly as well. So you can get it with and without the face. Now, heterotopies and the link with seizure disorders can be seen similar to anencephaly, even in absence of facial features. So when we're using medications in this population that's going to lower the seizure threshold, which you all know the ones that do, you need to be careful because heterotopies can be seen even without physical stigmata of the prenatal alcohol exposure. And when you think about that, these heterotopies leading to seizures, you can get the seizures even if you don't give them a medication, and they could be having seizures like absence seizures, and you're treating them for inattentive type of ADHD, right? And so that's one of the other reasons to really know, was this child prenatally exposed or not? So that said, brain abnormalities on MRI, if you choose to do an MRI, you can see compared to a normal brain, an individual with prenatal alcohol exposure, you see how the corpus callosum is a little thinner, and this area here is almost non-existent. You see the sulci and gyrite of the cortex a little bit thicker. And in this next individual, these are all images from Ed Riley and Sarah Matson from University of California, or San Diego State University. You see this individual's corpus callosum is almost non-existent, so it's partial agenesis of the corpus callosum. And the sulci and gyrite are a little more disorganized, and especially the prefrontal cortex. And then in this individual, they have complete agenesis of the corpus callosum with, much disorganization of the cortex. And this individual has holoprosencephaly. All of these individuals, these 4 here, have varying degrees of prenatal alcohol exposure. this individual having holoprosencephaly is going to be significantly impaired, right? But Dr. Sulik indicates that this condition, fetal alcohol spectrum disorder, is really a disorder of holoprosencephaly because it's varying degrees of holoprosencephaly. It's going from just midline changes like up here to all the way having only one brain, essentially, instead of having two separate hemispheres. So that said, brain wiring is different in individuals with prenatal alcohol exposure as well. Whereas you see in a normal, typical developing brain during adolescence, the wiring is beginning to come online to the higher level cortical regions and prefrontal cortex here, so that, let's say, messages from the amygdala and other more centrally located regions are going to be transmitted to the front of the brain for the executive functions, and to the higher level of brain functions to think and kind of problem solve and manage their world. You see the individual with prenatal alcohol exposure, the connections that would be made to the prefrontal cortex are actually looped back. Can you visualize that? How the wires are actually looping back, and that some of the biological wires here that would have normally connected to the higher level brain functions are actually clipped. Can you notice that they look like somebody has clipped them with scissors? So in fact, when they go into fight or flight, instead of being able to take it to the higher level brain functions or inhibit their behavior, they're shunting back to limbic. So I call this limbic seizures. And this is why I treat this as a condition of seizures for a lot of these kids. So when they have disruptive mood outbursts, instead of the parents sitting there and screaming at them, it's just like with my fainting goat who has seizures. She has myoclonic seizures, and that's what fainting goats do. I'm not going to sit there and scream at her when she's having a myoclonic seizure. I'm going to comfort her, and I'm going to make sure she's safe. And that's what we would do for a child who's having a seizure. So again, the amygdala gets fired and they go into fight or flight. And many of these children have already had years of trauma as well by the time we see them in the clinic. So there's the prenatal alcohol exposure, and then there's the trauma. So their amygdala fires, and in addition to it having effects on the higher brain functions, it's also affecting through the vagus nerve and other inputs and outputs, other areas of their body, as well as this executive control center in the prefrontal cortex. So many of the kids who we're seeing in schools with attention problems and other areas of executive functioning issues, if we were to help them and their parents, kind of understand the etiology behind their condition, I do feel that we could help them develop some of these and overcome some of their problems instead of just throwing medications at it. And again, going back to the term, neurodevelopmental disorders being functional birth defects, if we look at a lot of what we're seeing today in our clinics, and even NIMH is saying that many of these areas that are showing up in the adolescent years, like new onset schizophrenia, addictive disorders, anxiety, perceptual differences, many of these things we can trace back and say are really neurodevelopmental in origin. In the state of Maryland, we have a number of kids in our school systems that I've been advocating for, starting to look at how many of these children, percentage-wise, may have prenatal alcohol exposure, fetal alcohol spectrum disorder. And why is that instead of giving them labels like emotional disability or disruptive behaviors, we can begin to understand that, it's a wiring difference for these kids and start developing programs to help them. Now, going back to the prenatal period, someone this morning asked me how much effect other drugs have on neurodevelopment. And obviously, you know, any drug potentially could affect neurodevelopment. But for women who are alcoholic and or binge drinking, their blood alcohol concentration, their nutrition level, health, fitness level, genetics, timing, frequency, and duration of exposure all play a role. And if you look at fetal alcohol syndrome, that's just at one end of the reproductive health continuum that the children can be affected by. So women who use alcohol frequently have infertility problems. There are studies out of Scandinavia showing that in very large scale population-based studies. Miscarriage, infant death, any of these problems can be related to alcohol, and helping women understand that preconceptionally before they even get pregnant could help prevent some of that problem. Now, that said, it's not just prenatal problems, which is the first hit to neurodevelopment. It's ACEs, adverse childhood experiences, and then during adolescence, the individual using alcohol, tobacco, and other drugs during the time that their brain is rewiring. So for these kids with prenatal alcohol exposure, we want to protect them from these adverse childhood experiences, but unfortunately, many of them get the hits from ACEs before they even enter our clinics, right? So it's advocacy in the communities to help understand that it's all of these hits that do contribute to a child's long-term prognosis. And keeping these kids in particular away from alcohol, tobacco, other drug abuse. I teach them, because many of the kids that I see are adopted from Russia, the Ukraine, Eastern Europe, and from foster care. I teach them that they can never, ever have any alcohol. I talk to the parents about it. I say, don't have it in your house. Don't drink it in front of them. If they're at Catholic Mass, you do not give it to them. They don't smell it. And again, okay, maybe I'm stepping on people's toes, but these kids, it's like being allergic to chocolate when you're 4 and you go to your best friend's birthday party and they've served chocolate cake. You can teach a 4-year-old to stay away from chocolate, can't you? Yeah, you can teach them, pediatricians in the room, to stay away from peanuts, right? All their friends are eating peanut butter and jelly sandwiches for lunch. They don't get to sit with their friends. You can teach them that, right? We can teach children that they need to stay away from alcohol if we can teach them to stay away from chocolate and peanuts. Okay? It's just that our society is not doing that because we're inundated with Anheuser-Busch and Jim Beam and Jack Daniels and, oh, I'm going to be stepping on somebody's toes. I better keep going. Again, people are studying the neurobiology and neurodevelopmental impact of ACEs and prenatal alcohol exposure and finding that, and it's kind of a no-brainer, when you have both, it's a lot worse. Now, a problem that the CDC has identified, just looking at this from a global public health perspective, is that we know that 1 in 5 high school girls binge drink. We know that women who binge drink average about 6 drinks per binge. And what I told you was what? 4 to 5 is enough to cause this problem, right? And that 1 in 8 women binge drink about 3 times a month. Now, college girls are going out and they are partying. And these kind of episodes don't stop when they leave college many times. Well, maybe this stops because they get, you know, a little bit of decency and it shows up on social media, like I pulled this one off, you know, just some random, you know, who would want this kind of thing on social media? Like, really? I mean, anyway, but we know that prevalence of binge drinking has not, among women, has not really changed that much over, say a 15-year period. Drinking in pregnancy has pretty much been stable too. The reason that these rates were a lot lower here in 91 was that the Surgeon General's warning came out in 89. Well, it was mandated for alcohol. It actually came out in 81, but it wasn't mandated for alcohol until 89. And then between 89 and 91, the rates were pretty low. They went up by 400% right here. And it's these kids born to these women in the mid 90s. Do you see this 91 to 95? That are now in their 20s, and we're going to be seeing these, in the really correctional institutions is where we see them. And combined with these rates of drinking, binge drinking, we see that more than half of pregnancies are unintended in this country. So either mistimed or unwanted. You see half are intended, and then half are mistimed or unwanted. So knowing that, we also see a difference between ethnic groups of unplanned pregnancies, unintended pregnancies. And the CDC's concerns are that many women are at risk of alcohol-exposed pregnancies. So they actually came out with a warning and a recommendation in 2014 that led to an update on the Surgeon General's advisory to use contraceptives if you're using alcohol. And at that time, does anybody remember when that came out? Other than those that were in the talk this morning? So none of you heard about that, is that right? Am I clear on that? There's nobody in this room that heard about that new advisory. Okay, that is a concern that I'm going to take back to the CDC, first of all. But when it came out, the people who did hear about it, the 30-something women, and no offense to them, I was 30-something at one time as well, they had such a ruckus against the CDC saying, how dare the CDC tell them what to do due to a potential pregnancy, what to do with their bodies, right? But the CDC didn't come back with any of this information I've given you, that this is why we would do that, because it's these early stages of pregnancy. Now, as clinicians, you can do that in the privacy of your clinic. You can talk to your adolescent patients about this and let them know that if they're sexually active and using alcohol, they need to contracept, and here's why. It's because these problems happen before you know you're pregnant. If you were going to put a woman on Depakote, we talked about this morning, or lithium, or if you're a dermatologist and you're going to put them on a retinoic acid derivative, do you know what you have to do? Okay. Two forms of contraception. And every dermatologist will do a pregnancy test before they even give you your monthly Accutane or retinoic acid derivative. Accutane, retinol, there's a whole bunch of those. Even a 13-year-old who gets it is going to get a pregnancy test, and she's going to have to be on she's going to have to be on a contraceptive, and then they're going to recommend, if she has sex, to use condoms. Okay? So that said, in the treatment model that I've developed, and this is by no means, clinical, it's not gone through clinical trials of any kind, but I look at 4 domains of neurodevelopment. And you can do this for most of your patients, those with any neurodevelopmental disorder, you can look at it. But for these kids in particular, it's important because they do need a referral for sensory and motor issues a lot of times, and nobody's really looking into that. But some of the reasons that they have emotional outbursts relate to sensory issues. And a lot of times they'll get in trouble for knocking over and breaking something, and the parent gets really upset about that, like getting upset over spilled milk, right? And the child is clumsy and they can't help it. And many of these children have emotional regulation problems, which is why we end up seeing them, right? They get referred to psychiatrists, but we're not looking at these other domains to see how any of those are affecting their adaptive functions. And I feel like that's what we need to begin doing a little bit more of. So again, our neurocognitive functions, our executive functions, and our IQ, social communication, social perception is really big for these kids, the same as for autism. You know, these kids, unlike children with, say, Downs or other genetic issues, may or may not have these emotional regulation problems. These kids have a lot of problems. And again, it goes back to their wiring. And then sensory and motor. And for the moment, I want to spend a little bit of time. Let's see how much we have. So it's 10 till. Let me just quickly run through why this interoception, which we see as the seventh sense, is really a misunderstood problem for these kids. And if parents and caregivers could more or less understand how these children really are not correctly interpreting their signals from their body. And so it's like having a little 4-year-old that is sleepy or cranky because they're hungry, but they're not able to pick up on those cues because, you know, they don't have that wiring yet. For these kids, they may be 17 or 18 and still not picking up correctly on their cues, their body cues. So this is interoception. And if you think about interoception, people are calling that the seventh sense. It's because we have all these wires. We have more of these, you know, wires, biological wires in our gut than a full-grown dog has in its whole brain, right? So when we think about the gut-brain biome connection, and we talked about that a little bit this morning, how our gut is actually considered our second brain. I often say it's actually our first brain because primitive animals have the gut wiring that don't have an, you know, more or less external brain up here. We developed the external brain, like higher animals have this external brain. So these misrepresentations of internal states have been seen to underlie some mental disorders. So there have been people writing about many of the mental disorders that are due to interoceptive wiring differences. And certainly we can see that with some of the psychosomatic illnesses. Often we talk about shunting of arousal into our gut, right? Where you have arousal then going into your gut, and you might have irritable bowel syndrome or stomach aches, like kids ending up having stomach aches and school refusal because they're being bullied. I mean, we know all of this, but I'm just saying there's a way to teach parents that using diagrams so that they can see it visually and not just say, oh, it's all in their head, right? Because it's not all in their head. None of this is all in anybody's head. And these kids have limited psychological processes that the average person could use to overcome stressors. These kids don't have that. So we put them out into society when they're 18, not having recognized these problems, and they end up so-called psychotic because their brain is wired to, in the wrong places, it's wired to their auditory cortex or the visual cortex, and they end up, when they go into fight or flight, hearing or seeing things. And this has been shown in the schizophrenia research to be true, that for some people who have what we call schizophrenia, it's really because their brain is miswired. You guys know that, right? That schizophrenia now is seen as a neurodevelopmental issue? Most of you? Yeah, okay. I'm not just, I'm seeing some blank faces, so I'm not necessarily thinking that. So again, many of these conditions are seen as functional defects. These kids, like children who are on the autism spectrum, can't articulate their emotions very well. And again, the amygdala is a midline area organ. You know, we have two of them. And they have difficulty knowing and feeling the motivations of others. So in kids who end up in the correction system, they're seen as callous and emotional. I've written about this in my book, that many of these kids end up in detention centers and training schools. And right now in most counties and states in the nation, we have more mental health being carried on in jails and prisons than we do in communities. And that's a big problem, because these children need to be helped early on. And I would say the first thing you could do is develop an infants and toddlers program here in your Department of Psychiatry. And there would be funding that you could go out and get to have that happen. Because, you know, and I know that you have them embedded already in pediatrics, but families need to understand that they are contributing to this by not necessarily attuning and attaching the way they need to with these children, and being really harsh and punitive with them. So again, looking at their poor frustration tolerance and rage episodes as more like limbic seizures. If you do this, then you would begin to treat these disorders with medications like Lamictal and Neurontin, very mild anti-seizure medicines. And if you do that and a little bit of clonidine to help them sleep, alpha-adrenergic agonists. So remember, any medication I talk about in this population is going to be totally off-label, because there are no clinical trials for this population, right? Okay, so I'm talking about off-label use. I don't think you asked me about that in the disclosures, and I get nothing from pharmaceutical companies, but I'm telling you, I have found tremendous benefit, and the children do well with this type of medicine. Now that said, these kids are also high risk of abuse. I talked about the clumsiness before. It's teaching families to be more understanding of their deficits and not penalizing them, and to cocoon them from all of these shocks that the children are getting from just the ordinary daily life. Any degree of sensory inputs can be overwhelming for them. You know, going to the cafeteria at school can be overwhelming because of the sounds and the smells. You know, textures, temperatures, these can all be a problem for these kids. Facial expressions. Oftentimes the parents, one mom, lovely mom, works for a congressman, had adopted these two twin boys from Russia, and she and her husband, lovely couple. And one of the little boys was like maybe 6. They started working with me when the boys were 4, but he was about 6, and he and his brother were wrestling, and she's a very prim and proper mom. And she said to me that she looked at him like this, you know, because she had sent him into his room, and he kept looking out his room at her, and she was looking at him sternly, and she didn't understand what that did to him. But she was asking me why he reacted the way he did, which was shutting down and going to his room and just like being afraid to come out and interact with her. And I said, because he's not getting your facial expression, you know, and you don't want to use such harsh facial expressions. You want to be happy and, you know, loving and supportive. And not that parents have to be that all the time, but you want to know what you're doing to your child. And the parents do respond to this. You can talk with them. And I know that your program is not largely therapeutically oriented. I know that it's like very, this is what I'm hearing at least, that it's very psychopharmacology oriented. But these families can be helped. Maybe I'm wrong about what I just said, but we do have to talk to the families and help them understand these things. So working with kids at earlier ages, especially working with transitional youth and considering guardianship for these kids during their transition years, getting them on SSI, disability services, even though they may be working, they may not be able to work more than about 20 hours a week, a lot of them, because it is overwhelming. It's just like being overwhelmed by being in the school system and having longer duration before they graduate. So getting them in the like 5-year high school plans, and then a transition plan through to adulthood, and really helping them achieve meaning and purpose in their life, which every young adult needs, but these kids are going to have a harder time achieving meaning and purpose. So helping them from an early age find out what their gifts are and what their strengths are, and lifting them up rather than showing them what they can't do. So that said, I do find that helping the child understand the special needs from an early age is helpful, and helping the community itself cocoon them, and being someone who works with parents, helping them go through the grieving period of having a child with this condition, rather than later on feeling guilty about having beaten and abused the child when this was not the child's fault. That's more helpful. And as clinicians, you can begin working in what I call the 3-dimensional Rubik's Cube, so that case managers or psychiatrists or speech and language pathologists, anybody can be at the center of the Rubik's Cube. Like this one has a psychiatrist in the middle. I used to only show this with psychiatrists in the middle, and I went and I spoke in Arkansas at a multidisciplinary conference, and the geneticist would say they should be in the middle. Anybody can be in the middle of this kind of help. And then teaching the parents awareness, acceptance, attunement, and then the child adaptive functioning, and allowing opportunities for them to achieve Maslow's hierarchy will be very helpful. So with that said, you know, I'm gonna pause for questions because I'm out of time. If you want to find out more, I do have a website, prenatalalcoholexposure.com. Has a link to my book. So, thank you for your attention. Anybody have any questions? No questions for Susan? Thank you.
Thank you.
Thank you.
I know I didn't answer all your questions, but if you have any more, you can reach out by the internet.
Thank you all.
I hope it was helpful.